So I'd like to welcome you all to the third Niche to Necessity webinar that the North West and the North East and Yorkshire have put on for you all. I'd like to reference the Niche to Necessity title. This was from Tiggy Johnston-Burt, who is a colleague of Tracy Miles, who works in the South West GMSA. I'm the nurse director for the North East and Yorkshire and the lead nurse for the Northwest GMSA. And so I'd like to thank you all for joining us all today. After the webinar, The Circle of Life, I hope you will have increased your genomic confidence and feel more positive about using genomic knowledge moving forward. There are a few general housekeeping rules that I'd like to talk you through. So as I said before, we're delighted that you have joined us today. We will be recording this webinar, so if you don't wish to be seen, then please leave your cameras off due to the number of attendees, and please keep your microphone on mute throughout. We will be holding live polling during the session, but if you'd like to ask any specific questions, then please share in the chat box, as we will be holding a question and answer session at the end of the webinar. Feedback will obviously help us to inform future events, training and engagement, so we would value your thoughts on the topics discussed. A feedback form will be shared after the webinar, and upon receipt we will share confirmation of your attendance today. Thanks again for joining us, and I'd now like to hand you over to Marie Kerwin, who is the lead nurse for adults in both the North West and the North East GMSA. Thank you all.
Hello and welcome to everybody. We're delighted that you've been able to join the Northwest, Northeast and Yorkshire today. And the next slide, please, will give us an indicator of the programme for today's Niche to Necessity. And we've called it a Circle of Life. So very much a reference to the Lion King, you know, taking us through that journey from the beginning through to the whole of the life cycle, where genomics is very important. So without further ado, I'm going to go over to our first speaker, who is Wahida Abbas, who will introduce herself and the recipe of life epigenetics. Thank you.
Hi, good afternoon, everyone. My name is Wahida Abbas. I'm lead midwife for genomics at Northwest GMSA. Today, I'll be talking about the recipe of life, which I've called epigenetics, just to stay with the theme. Could we have the next slide, please? So, recipe of our life. So, I've got a picture off there. I mean, it's showing spices and etc. So, the total of our genes, it's like a recipe book. We own our own cookbook. We get to decide which recipe we will and won't make. We also decide which recipes we make more often or less often, and the same goes for activating our genes and producing proteins. Factors such as how much we exercise, the food we eat, the drugs we consume, and the toxin we're exposed to, as well as stress we're under, and even the emotions we feel and they all interact with our genes. And this influences how the recipe is read and how the proteins are produced. In other words, environmental factors such as including our thoughts, beliefs, preparations, they all interact with our genes, and this influences how the genes are expressed. And this in turn determines every facet of our health. This is known as epigenetics. Next slide, please. So findings in epigenetics suggest that there are links between maternal behaviour and the experiences during pregnancy, after birth, and the subsequent well-being of our children and the future generations. So things like smoking, alcohol, drug intake, whether it's before conception or during pregnancy, other examples we can include our poor prenatal diet, prenatal exposure to domestic violence, and maternal distress, and also intrapartum the mode of delivery that has an impact on the way our genes are expressed, and comorbidities are all linked to epigenetic changes that may cause health problems in the child. So as midwives, we need to have a knowledge base of epigenetics and its impact on pregnancy. It's pertinent for the booking midwife to take a detailed booking assessment and ensure accurate lifestyle choices are documented, and also, what kind of comorbidities have any other risk factors, and then taking that into account when we developing antenatal, intrapartum, and postnatal care plans. Next slide, please. So every midwife obstetrician will be aware of this risk assessment, a screening timeline. This shows each contact we have with a pregnant person during the pregnant person's journey. So initial booking appointment is conducted to gather all information about the life choices, lifestyles, in term recipe of what their life is about. And as a midwife, we need to assess which are the risk factors which can have an impact on the pregnancy and also on the fetus, which can change the gene expressions and have implications for during intrapartum care and postnatal and impact on the child. Next slide, please. Thank you. So looking at the journey and looking at different areas of epigenetics, a few things I'm going to focus on, which I've put on this slide. So firstly, looking at how IVF can have an impact with epigenetics. So there are several studies that have indicated that IVF is associated with fetal growth restriction, prematurity, low birth weight for gestational age, and an increased risk of cardiovascular malformations and other defects. Long-term follow-up studies have suggested a potential increase in the incidence of elevated blood pressure and fasting glucose, an increase in total body fat in IVF babies. Therefore, this can lead to implications in cardiovascular remodeling that persists in the human fetal and postnatal development. And then look at smoking. Everybody knows about smoking and how it has an impact in pregnancy. And the period of in utero development is one of the most critical windows during which adverse intrauterine conditions and exposures can influence the growth and development of the fetus. So smoking during pregnancy remains, it's very common, but obviously we know its hazards, such as, prenatal exposure it reduces birth weight, poor development and psychological outcomes, and increased risk for diseases and behavioural disorders later in life, which are all epigenetics. So with the smoking, the way epigenetics is as an impact is it alters the DNA methylation and dysregulates expression of microRNA. So epigenetics of maternal cigarette smoking during pregnancy, these changes can affect the child when it's born in later life, such as its health implications I've already mentioned and behaviours. Looking at maternal nutrition. Nutrition is the most critical environmental factor, and it influences early development and processing by regulating epigenetic mechanisms during pregnancy and neonatal periods. Maternal diets or nutritional compositions contribute to the formation of epigenetics profiles in the fetus that profoundly impact individual susceptibility to certain diseases and disorders in the child later life. So some of the studies have shown that maternal nutrition status is closely associated with obesity, which it's quite common, we all know that. And hence that's why when we're doing the booking assessment, we'll look at the BMI of each person. Maternal diets may also impact the early establishment of the fetal and neonatal, which can lead to specific epigenetic changes, and it's potentially predisposes to the development of late life obesity. So it links from, clearly from preconception to pregnancy, then also as a child progresses through life into adulthood. And then I'm just going to talk about COVID-19. So when COVID-19 was about, the research suggested that it induced quite like a psychological social stresses because the pregnant women were isolated and they were restricted from social activities. Hence, this led to having trouble sleeping, and the lockdown had more implications. So during pregnancy, these psychosocial stress factors can affect the fetus's brain development and obviously the maturation of the brain. And because of that time, there was no kind of prompt psychological interventions. So this had quite a heavy impact on maternal elaboration, as well as, risk factors of fetal and child somatic mental disorders in later life. And we can see that as children are born from the COVID period, there is an implication in the children when they've gone to nursery, etc. They feel as though there's more attachment with their mother, but they don't feel as though they want to kind of socialize with other groups. So if you look at the education, the nursery education and infant schools, the teachers are saying that they've noticed that it has a big impact on the child. So it all is related to epigenetics. So looking at alcohol, which is another common theme, and it's one of the booking assessment questions we ask about alcohol. So alcohol-related neonatal abnormalities, they're known as fetal alcohol spectrum disorder, so FASD. This is a severe form, and it's also known as fecal alcohol syndrome. And this can have an impact on the brain growth, facial abnormalities, and has an impact on central nervous system. So even though there is no specific time point during gestation when harmful consequences occur, so as they go through the pregnancy and the fetus is exposed to alcohol, what they're saying is during the embryonic stage, this is where most of the congenital disabilities occur. And what happens is, because the alcohol, it interferes with the gene expression levels, and hence the epigenetic processes that alter the DNA methylation and histone regulation, and also the non-coding RNAs. So alcohol also induces alterations in the methylome of the hypothalamus, which is a brain, and this includes several differentially methylated regions. And these are the signs and the symptoms that are observed once the baby is born. And the other area we're going to look at is mental health, which I've already discussed briefly around about COVID. So maternal stress before, during, after pregnancy, this profoundly affects the development and lifelong function of the infant's neurocognitive development. So they've done quite a lot of studies, and they're saying during the gestational periods, because the fetus is exposed to the maternal stresses, it can lead to behavioural, cognitive and temperamental disorders in the infant, which increases child morbidity and also neurological dysfunctions. An example is during maternal psychosocial stress, it increases, it has impact on the infant growing, and it develops odds such as, you've probably heard quite a lot of this, ADHD and autism spectrum disorders, and also it can have an impact on sleep disturbances, and this hence leads to depression and other psychiatric disorders. So next slide, please. So when we've all been to school, college, we've all learned about nature and nurture debate, but epigenetic is saying that the old that the old idea that genes are set in stone or that they are long determined development it's been disproven. So nature versus nurture is no longer a debate. It's nearly always both, which makes your epigenetics. Next slide, please. So in summary, epigenetics is relatively it's new and fascinating area of scientific investigation. It's a study of how environmental factors alter the expression of our genes and how this may have an impact on maternal health. Gene expression is how our genetic material is translated into our physical characteristics. For example, the issues I've mentioned, nutritional, environmental factors, lifestyle choices, they can all impact our gene expression, our recipe of life. These factors do not cause mutations in your genetic code, which is really key because it does not change the DNA code. Rather, it's how your genes are expressed. So the changes may be permanent and can be passed on from generation to generations. So obviously, when we're booking our women, obviously every contact we have our women, we need to be educating pregnant people and their families about adapting the lifestyle choices, referring to smoking cessation, dietitians, and that's one thing I don't really see that. Even the woman, if she's got a low BMI or a high BM, not much is done about referring women to dietitians, and that's quite key. Next slide, please. Next slide. Okay.
Thank you very,
All right,
very
thank you.
much. That was absolutely brilliant. So we've just got a couple of minutes for a question that's come in, if you don't mind. And the
Go for it.
question is, what got you interested in epigenetics? And then secondly, how do you see that the midwife role expanding due to epigenetics? Thank you.
So the first question that was how I, got into this talking about epigenetic. What interested me was last year I was approached by Population Health to talk about epigenetics, and firstly I thought I don't have a clue about epigenetics. And as every midwife would say the same. And then as I looked into it, and I thought, actually, I know a lot about epigenetics because it's every day of our job. We talk about diet, we talk about lifestyle, the house you live in, the weather, and it all has an impact on our lives. So that's what really interested me in it. And I think with every person, whether you're pregnant or you're not pregnant, or you know, every comorbidity, it has an impact, and that's what interested me, and I find it really, really fascinating. And the second question, Marie.
How do you see the epigenetics expanding the role of the midwife going forward?
So epigenetics is now in the NMSC standards of midwifery and nursing education, so it is part of the role. And I think we already are talking about epigenetics, but we don't make the links. We're not bridging that knowledge with epigenetics because we don't associate the words. But we are at booking visits. We are asking about mental health disorders. We are asking about smoking, cardiac conditions, but we're not actually using the term epigenetics. But we are doing the job of it, so it is in your role as we speak. But it's just making them associations.
That's been really, really helpful. And thank you so much, Wahida,
Thank
for
you.
working with us today on the recipe of life.
Thank
So,
you.
audience, just a couple of reminders that there is a poll that's open in the chat at the very, very beginning. So if you've been only joined us recently, if you scroll up to the beginning of the poll, there's just 3 questions that we would like you to answer. And that is great. So I am delighted to welcome our next speaker, who is my friend and colleague, Denise Barnes. And the title of her talk is Be Prepared. Over to you, Denise.
Thanks, Marie, and yeah, thanks everyone for joining today. So I've joined today to give an overview of genomics in maternity care and how you can be prepared. And if you feel inspired to comment on anything I discussed today or want to ask anything, please add that to the chat box as we go along. Next slide, please. So I'm sure some of you sang The Circle of Life from The Lion King when you got the invitation. So I'm going to put another song in your head, but I'm not going to sing, don't worry, Marie would kill me. But one of the verses of this song is Be Prepared from The Lion King. And I feel this really describes my thoughts on genomics and the theme for my presentation today. So genomics is expanding into all areas of healthcare, and it's exciting, and we are definitely in a new era of healthcare. The word genomics is now being used more accurately to describe the potential of testing the whole genome and the increased improvements in healthcare it creates by predicting, preparing and personalising the care and treatment that we can offer. But how do we know who it's relevant to in midwifery, and how can we be prepared? Next slide, please. So as midwives, we're already ahead with genomics. This image is familiar, Wahida's already shared it today, and it's the screening timeline and shows the key touch points on the care pathway of where antenatal and newborn screening is performed. And this also provides us with a framework when exploring genomics in maternity care. Next slide, please. So let's look at some of the opportunities for genomics in pregnancy. We'll start from the beginning in the maternity circle of life and the prenatal or preconception clinics in primary or secondary care. If there's a family history of a suspected or confirmed genetic condition, healthcare professionals and families have the opportunity to have appropriate conversations and referrals into genomic services. Antenatally, during pregnancy, pregnant people or women can often now self-refer into maternity services, and the aim of this is to provide a more timely access to maternity care. But what information is captured on that form for the self-referral, and could it be improved to empower the pregnant person to provide relevant information and improve a more timely access to perinatal genomic services like clinical genetics and fetal medicine? The booking appointment provides the opportunity to take a family history, as well as a million other jobs. But when you're taking a family history, how do the families know what's relevant? And we have to be really mindful there may be a stigma attached to that condition, or it's seen as a curse or a result of something they've done wrong in their life. And some women don't want to book the pregnancy because if the baby was affected with a genetic condition that they know of, they wouldn't continue the pregnancy. So it's really worth considering how your service supports these families. If you have a family who receive an unexpected scan finding at the dating or anatomy scan, do we explore if there's a family history there? Are they related outside of marriage? And also to consider, how aware are you of the National Genomic Test Directory? Because this is the directory that sets out the criteria for eligibility for whole exome sequencing and whole genome sequencing. And it's updated regularly, but how does your service ensure you have equitable access to that offer and performance of the test? It does rely on a detailed phenotype, so do you refer for a second opinion in the tertiary centres, or do you manage them in-house, ensuring you've got equity of access? Following the birth, there may be an obvious fetal anomaly. Again, following the National Genomic Test Directory for the R14 pathway for critically unwell babies, but you may be a midwife performing the newborn examination and a family might disclose to you family history of something. Or you may be looking after a family that have a pregnancy loss. And in that really sad situation, being able to have a really informed discussion with the family around genetic testing, if you've ruled out other reasons such as placental insufficiency, infection, abruption, what does that informed offer of genetic tests look like in your service? So there are multiple opportunities to discuss genomics in pregnancy, but does this mean that all families should be referred to the perinatal genomic services? No. It means we should be aware of what is available and then create a personalised offer, taking into account what matters to them. And as healthcare professionals, we're familiar with the concept of offering personalised care. We try to explore what matters to the families we are looking after, being mindful of cultural sensitivities, which I'm sure Dr. Sagira Malik will talk about more in her presentation coming up. The challenge is always how we ensure that an informed offer and shared decision making has occurred and documented, especially with the time constraints we have in appointments. The success of the introduction of genomics generally has been measured as an increase in the number of tests being performed. And you can see how that would work in cancer care, for example. However, in maternity, we need to capture the offer of referral and testing. And as part of our new perinatal genomics transformation project in North Eastern Yorkshire, we hope to be able to explore this personalised offer of referral, and any suggestions as to how we can improve this will be gratefully received. So when looking at a family's access to perinatal genomic services like clinical genetics and fetal medicine services, there are different structures and referral pathways locally, but they shouldn't affect the equity of access to genomic investigations and care, but sometimes there are unintended barriers in place. And I like this image, it helps to show what equity looks like. The end result is the same, they can all view the baseball game that's going on, but their individual differences have been considered and personalised steps put into place to remove those barriers, or the fence in this case. So what does your pathway look like? Does it allow for families with different needs? And are we leaving ourselves open to litigation if we fail to offer a family testing when the tests are available? What will affect equity of access is our lack of awareness. So, in response to that, the North Eastern Yorkshire Fetal Genomics Transformation Project created some resources to help increase awareness. This quick reference flashcard provides more information around questions to ask to identify families that might have or be at risk of a relevant genetic condition. And this has been made into a more generic resource that you can have local logos added to. It's all on our North Eastern Yorkshire GMS website, along with some amazing videos designed to support pregnant people when considering invasive testing during pregnancy. So what if you're not sure? If you think a family might need to be referred to perinatal genomic services, do you go 50-50? Yes, maybe, or no? Do you ask the audience? Is that your colleagues in the antenatal clinic or the family in front of you? Or do you phone a friend? And if your friend is in clinical genetics, then yes. But rather than phone in, next slide, please. If you have a gap in your knowledge, send a GAP enquiry email. And GAP stands for Genetics Advice in Pregnancy. So in North Eastern Yorkshire, the clinical genetics services are supporting GAP enquiries. So you put GAP into the subject of the email and it will highlight to clinical genetics that it's an urgent inquiry, and they'll respond to you with the recommendations. If they recommend a referral is required, please inform that pregnant person. And this could be used as a wider rollout in areas. However, colleagues in clinical genetics are more than welcome to enquiries because we don't need to know everything. So in summary, you already know your pregnancy timeline, but consider how you can be prepared and increase your awareness of which families could have a history of a genetic condition or a genetic red flag. And have a look at the flashcards and see if you can use them to aid a more timely offer of referral. We aim for an informed offer of referral to relevant perinatal genomic services and document the outcome if accepted or declined. And that should be a personalised offer in a culturally sensitive manner. There's also an e-learning related to this on e-learning for healthcare. And if you have a gap in your knowledge, which we all do, seek advice. Send a gap inquiry email or speak to a local clinical genetics colleague. Thank you. I welcome any questions.
Absolutely brilliant, Denise. Thank you so much. And one of the things that comes to me from your talk there is that people are not on their own, that there's support out there, and just being given that reassurance that there's people that they can come to. If anybody has got a question, if you could put it in the chat, that would be absolutely brilliant. And we have actually got a question from Heather. GAP. Who would you contact if not in the North Eastern Yorkshire? Is there going to be a national helpline for advice?
Yeah, so the GAP inquiry is a local initiative at the moment, but we're hoping as part of the next project, the Perinatal Genomics Transformation Project, some of these resources that we've put into place. are being evaluated and hopefully be moved forward into a more wider reach. But the clinical genetic services, I'm sure Sagira will back me up on this, are very amenable to having inquiries. What we don't want to do is to think that we don't know and do nothing about it. So just reaching out to your colleagues in clinical genetics, whichever your local service is, I'm sure they'll be more than happy to offer some advice and support.
And alternatively, we've got a website for the North East in Yorkshire. We've got a website for the North West Genomic Medicine Service Alliances. So people can always reach out for us through that mechanism as well, can they?
Yes, yes.
Yeah. So I think for me is one of the questions that's coming through is that how did you actually get interested in genomics in the first place regarding midwifery?
Oh, so my background is fetal medicine and screening. So I just love being able to support families in a really difficult situation, but making sure they have the right information at the right time. And being able to work in a tertiary centre as I have done, I've been really aware that I've been quite fortunate in my experience and the colleagues that I've made around that area. And some of my colleagues outside of tertiary centres aren't quite as fortunate. So I feel really strongly that if I've got information that I can share, I want people to come along with me. So that's why I do it.
Brilliant. So on the back of that last comment, what is the easiest way to bring genomics into midwifery practice if somebody isn't in a tertiary centre? So what's the easiest way that they could?
I think making links within the multidisciplinary team. So I know there's now a bigger reach to encourage people not to work in isolation. And I think it's quite difficult when you're in a smaller unit and you've got a very big geographical area to try and support families. But there's a bigger multidisciplinary team now coming around. So I think linking in with myself or similar people in the region will really help to increase your awareness and explore your own pathways. Take a fresh eye and look at your pathway and see how does that support the families that you're looking after.
Lovely. And Alison Bradley is asking, how much does it actually cost a trust to have the testing done? Well, it's quite a specific question. So is that something that you would know, or
a lot of the tests now during the that are in the National Test Directory are all funded through the NHS, which is why we're now able to offer them. That's great if you're aware of them. So that's what the main point of my presentation really was, is to increase that awareness. It's not at a cost of the test, it's a cost of staff time to be able to give the right information to that family. But you also need to allow time to learn about those tests as well beforehand.
Yeah, absolutely. And that's the whole secret to the be prepared.
Yeah.
I thank you so sincerely. Any other questions that come into the chat, we will be able to forward to you, Denise. But thank you so much for joining us today, and a fantastic presentation. And Alison says thank you. That's a pleasure. I am thrilled now to be able to go to our next speaker, and we're delighted to have with us today Sagira. So Sagira is going to be presenting culturally competent genomic care. Over to you, Sagira.
Thank you very much. Thank you very much. Good afternoon, everyone. I'm delighted to be here. I work very closely with Denise, so thank you very much for your excellent talk. You've already done half of my work with the genomic knowledge. So as you can see, I'm a lead genetic counselor for prenatal genetic at Yorkshire Regional Genetic Service. And in addition to that role, I'm passionate about developing culturally competent genomic care. And it's important that all healthcare professionals across all healthcare specialties understand the underpinning context of culturally competent genomic care and why it's important for our clinical practice. Next slide, please. As you all know, that genomic policy document currently talking about the clinical, scientific, and ethical imperative of inclusion, diversity in our whole genomic ecosystem. There are multiple definitions of EDI, but in genomic context, it's simply ensuring that genomic is for all by provision of an equitable healthcare, which value differences and involve everyone, so the clinical benefit of genomic advances are shared across populations. However, due to kind of multiple factors, and 10 minutes will not be enough for me to go through all those factors. Our scientific knowledge about the different genomic variation and pharmacogenomic variation across population remain limited, and there is a poor and persistent kind of trend that the diverse communities are underrepresented in genomic studies. Like I said, there are other multiple factors, and it's difficult, but I believe that one of the factors is that our current healthcare professionals, our workforce is not up to date with these advances. I contribute to national and international genomic policy meeting as well, and I reinforce my point all the time that the genomic advances are not in parallel with the workforce development. So in order to enhance inclusion and diversity, one of the strategy is that our genomic health force or our workforce develop genomic knowledge and sensitive communication strategy to engage patients from the diverse community in a culturally competent manner. Next slide, please. Culturally competent care mean that we have a knowledge, cultural knowledge about our communities. We have genomic knowledge about all those advances Denise has mentioned and Bahida has already explained. And effective communication skill. At Yorkshire, based on both my clinical and research experience with British Pakistani population and recruiting a large cohort of British Pakistani population in 3 large genomic studies over the year, which has improved the equity of access, which has helped us to identify almost over 54 genes before these genomic advances were there, and help us to translate that research knowledge into clinical practice, and empowered our British Pakistani family to make an informed decision regarding their reproductive choices and the carrier testing in pregnancy, and testing option for the carrier testing option for their extended family as well. Based on that knowledge and the reflection of that successful approach, I have decided to use my theoretical knowledge to inform the clinical practice and propose this model of culturally competent genomic care. As you can see, this framework comprises of 3 core concepts: cultural competency, genomic competency, research competency, and I will go through the following slide explaining these all. The area of overlap between these 3 ensures safe, ethical, and effective clinical practice in the delivery of culturally competent genomic care. We all know that effective communication is the central concept of this framework, where all these core competencies are embedded. Healthcare system play a multiple role. One of the role is the workforce development and provision for a culturally competent educational resources for our healthcare professionals. I have passed on this framework, so we will ensure that you all get the detailed version of that. I understand that you may not all be involved with the multiple stages of genetic testing and consultation. So we have provided some competency statement with all core concepts, so that, and with a practice indicator as well. So you can identify a gap in your training or gap in your knowledge, and then accordingly set your objective to meet your need in alliance with this culturally competent genomic framework. Next slide, please. Genomic competencies. Genomic competency is the healthcare professional knowledge and understanding of the genomic concept and the ability to translate that knowledge to inform clinical practice. Genomic knowledge involves that we all understand that the diversity of a rich population or rich human population reflect the biological consequences of DNA recombination. We all are descended from an African lineage, so we have more similarities than differences. However, there are underpinning or underlying genomic variations that affect the disease pathology. analysis of that condition, and determining the risk of that particular disorder, support accurate diagnosis, and inform both clinical and pharmacogenomic pathway for rare and common diseases as well. Personalized medicine required that we understand that how we can optimize dose, duration of that treatment, side effect for our patient. The studies, global studies on EDI have indicated that the importance of EDI in the genomic studies and highlighted that why one particular drug doesn't work with the other group, because the genomic variation found in one may not be relevant to the other. So it's important, this is our knowledge, that we enhance our genomic competencies. Next slide, please. Likewise, arranging an interpreter is not a culturally competent practice. It's important that we understand the structure of our local population. We understand that who is the largest ethnic group here, what are the communication barriers here, level of their health and genomic literacy. It's important to understand that for some population, their health literacy may be limited, so let alone understanding the genomic concept would be very challenging for those. There are back-to-back studies in the UK, one with the British population, and 80% of that, the British population doesn't know, whose first language is English, that what genomic is. Likewise, there's another study with a healthcare professional where it says about 82% healthcare professionals don't know what genomic is. So you can imagine the scale of that problem for someone who doesn't speak English. Again, understanding their cultural value, strong religious belief about reproductive option, their attitude toward the prenatal diagnosis, carrier testing, termination of pregnancy. As a midwife, it is important for us to know the termination of pregnancy in Muslim family is not allowed beyond 120 days if there is something wrong with the fetus, which is 17 weeks. So it is important that we make those timely referrals so that the family who really wants to utilize those genomic information for their clinical benefits are referred at about the booking appointment, not by the time they're 16 weeks pregnant, because that's not going to be useful for them. Same, understanding family dynamics and how can they influence reproductive decision making. Non-disclosure of genomic information for at-risk relative, and why is that? For some community who are English-speaking community, there are concerned about the use of the genomic data. So culture competency is important, that we have very good insight about all these information, and a cultural knowledge and awareness that we have this knowledge, which will enable us to provide a targeted, sensitive communications communication strategy, to develop sensitive communication strategy targeted at that population. Next slide, please. I put that genomic and research competencies as well. As you can see, there is one of the consanguis family, and despite all the recent genomic advances, they've got 3 children. We still have got no diagnosis for that. So this is just one of the hypothetical case based on the real experience in Yorkshire. We understand genomic competencies, that we understand that genetic testing is out there, which can help us support personalized medicine. However, when there is no genetic diagnosis as a healthcare professional, it's important that we discuss these cases in our MDT meeting and understand the importance of diagnosis, not just for consanguis family, for any families, because there are long-standing social, psychological, emotional aspect of these diagnostic challenge for the family. Multiple NHS appointments, strain on their relationship, it's practical barriers. So it's important that we understand if there's a genetic research study looking into 100K genomic data and can provide a answer, it's important to understand what's the requirement of a protocol and the requirement of that study, what's the requirement regarding if they need any sample, what's the turnaround time of that testing, consent and confidentiality, and if there is a plan in place to communicate those results. Next slide, please. Consanguinity in some areas, it's important. It's a cultural competency to understand that there are advantage, there are cultural, social, and economical benefit of the family for our consanguineous marriages. At the same time, there are scientific aspects of consanguinity, and consanguinity act as a tool because the identification of homozygous variant can help us to identify the new gene for that disease in that family, but also help us to prove or disapprove the pathogenicity of a variant in non-consanguineous family. So these insights are extremely important for developing improved clinical and pharmacogenomic pathways. Next slide, please. This is one of the prenatal cases, and I know that there are a lot of midwives out here, so I've just put that case just to highlight some key aspect here as well. As you can see with the arrow, the proband is in consanguineous relationship. She's currently 8 weeks pregnant. Her sister, who's also married with a cousin, has got 2 children with a known genetic disorder. So if this lady approach you, refer her to genetic. Don't try to calculate her risk yourself. Don't make any assumption. Clinical genetic is there, like Denise has clearly explained to you. Please pick up the phone and speak with us. In a scenario, because timing is important, termination of pregnancy guidelines are important. In a scenario, I put that there's a diagnosis there, but if there's no diagnosis there, again, please send us this family because there are a lot of advances. And if that we have not seen the affected children since long time, we can still offer them testing through the R14, which was on Denise's slide as well. So testing for the sick baby, we can get the result in 3 weeks time, which may help your patient to have a carrier testing and her husband. So please consider the timing. Please have this genomic and culturally competent knowledge and make timely referral. Next slide, please. Healthcare system can play a huge role in developing culturally competent process. And as I put that down, that strong political willingness with the strategic leadership is very important that we develop policies, we enhance genetic literacy, not because if you have cultural competency and unable to explain the genomic concept, that's not use. So you need all these concepts in parallel, in a synergy to deliver that. And it's not just one, it's not healthcare professional responsibility. It is the responsibility of all of us that we deliver that service which meet the cultural and communication needs of our client. And it is, we all as both healthcare professional and healthcare organization need to have that knowledge to deliver in the client cultural context. I think together we can make it possible. I landed in this country 20 years ago, so if I can develop, anyone can develop. Thank you very much.
Sagira, thank you so much. That was absolutely brilliant. And just hearing how we get from cultural sensitivities to cultural competence. We have got quite a few questions, but in the interest of time, I'm just going to focus on one that came in quite soon. And that is from Naomi Fraser from Clatterbridge. She's wondering, is there shame in some communities regarding genetic diseases that they feel that the family must have done something to cause it?
There's no shame in there. I think it's the way we communicate risk to them. Because if you look at that, the other day I received a referral from a midwife asking me that I'm going to refer this family. There's only consanguinity here, no family history. So we don't make those referrals if there is no known family history. So I think it's the way, and we explain this, that ultimately, like consanguinity, the way we discuss consanguinity, I don't ever speak with my patient that it happened because you are cousin. I always say it happened because you both are a carrier. And we all are a carrier of something, regardless of where we come from. It's only for recessive condition, if our partner is the carrier of the same, then there is a risk 1 in 4. So it's the strategy we use when we communicate these sensitive scenario and put patient in that kind of that they blame themselves. So it's very important that we adopt a sensitive strategies and use those all contexts in a way that patient don't feel that why would somebody be ashamed of or that they've got this burden of genetic condition.
Yeah, absolutely. And that was such an important question to have asked. And we'd like to explore that a bit further in the question and answers at the end of the webinar later. But thank you so much, Sagira. It absolutely it's such a critical part of our roles, whoever we are, wherever we are, about how we give the messages, how we sensitively give that. So thank you so much, Sagira. We're delighted to have you with us today. We're
Thank
going
you
to
very
go
much.
through. Oh, brilliant! You're here for the Q&A, aren't you?
I am, and I've requested to circulate this the model, the framework I've developed. It's slowly getting momentum within the genomic education program and health policy document here around the country and globally. So, as you know, development of these things is always slow. So we are trying hard.
Well, we're going to help you in that. So thank you so much. We are delighted now that we're going to go to break because you've all been working hard on concentrating. So we're just going to have a quick break, stretch, have a drink, comfort break, whatever you wish. And we'll see you back here prompt at 3 o'clock. Thank you very much, everybody.
Can I just check in the minutes before I start that my audio is working and people can hear me?
Hear you loud and clear, Jonathan.
Brilliant.
So we're just about to turn on to 3 o'clock. Just wait for just 30 seconds until we see everybody coming back. Really hoping that everybody has enjoyed the first half. I erroneously mentioned a Q&A. So there isn't actually an independent Q&A at the end of the webinar today. It's questions as we go with our speakers. So welcome back everybody from the break, and I am thrilled to be able to welcome our colleague John Roberts, who is going to be talking us through the generation study of genomic sequencing newborns. Over to you, John. Thank you.
Thanks. Really nice to be here. So by way of introduction, my name is Jonathan Roberts. I'm a genetic counsellor. I work both in the NHS at Addenbrooke's and also on the generation study as part of the newborn screening programme at Genomics England. So next slide, please. So briefly today, we'll do a little bit about Genomics England, the current newborn screening, the generation study and what we're doing, some of the information about how we've been selecting the genes and variants, and then a little bit about the patient journey and study endpoints. I'm going to try and keep quite tight to the 10 minutes, so we've got good time for questions. Next slide, please. So for people not familiar, Genomics England grew out of the 100,000 Genomes project. It is a PLC, but a Department of Health owned, so it's a sort of slightly hybrid company in that sense. And it has two core functions: to support the evaluation in genomic healthcare and to accelerate genomic research, both of which you'll see coming out in the genome study, in the generation study of the newborn screening programme. And we work with the NHS. Again, that was part of the 100,000 Genome Project. Strong collaboration with the NHS to deliver and improve testing with the aim of helping doctors treat, prevent illness like cancer and rare disease, and to provide health data to advance research. Next slide, please. So the current newborn study has this 9, possibly 10, and then also sort of expanded selection of conditions that are tested for. This is the heel prick test that's done normally on about day 5, and is primarily biochemical and has a very high uptake. So it's about 97% uptake of newborn screening in the UK. NHS screening only looks for these conditions currently on the newborn blood spot. And what we are doing is to see if genetic testing can be used to broaden the range of conditions, so to broaden this approach. At least that's the aim as it relates to newborn screening. Next slide, please. So we are planning to recruit 100,000 newborns, and the generation study has 3 aims. So the first relates to newborn screening. So this will use genetic testing to screen for over 200 conditions, so a significant expansion on the current newborn screening, and this will be done in conjunction with the NHS. The second part will be to understand how babies' genomic data could be used for discovery research. The focus will be on developing new treatments and diagnostics for NHS patients. And then the third part is exploring what the risks and benefits would be of storing the baby's genome to be used as a resource over their lifetime. So we will primarily focus on the newborn screening aspect today, but keeping in mind that there are two other important areas in which this study is looking at. In particular, in related to the newborn screening, one of the evaluation endpoints is not just how might we implement these, but whether they should be implemented. So there is a sort of a sense of conducting research without having predetermined what we think. So it's a case of, is this the right way to be expanding newborn screening? As opposed to just how. Obviously, how is really important in making sure this is done safely and effectively with the NHS, but at the same time, the question is whether this should be done. Next slide, please. So a question then would be what conditions to screen for. So there are thousands of conditions that could be detected through whole genome sequencing, and we're not going to look at all of them. And also, this program will only be testing for a specific set of conditions, genes, and importantly, variants. So when we think of whole genome sequencing, we are most used to thinking about this, I think, in a diagnostic setting. And this is a screening setting, which is different. And the reason that we'd only be testing for specific variants is we don't want uncertain results. So we are limiting the analysis to known pathogenic and likely pathogenic variants. And the principles and criteria for screening already exist. We're taking a bespoke approach to try and gain maximum benefit from this test with the minimization of the risks. So if you go on to the next slide, so you can scan the QR code, which will give you a bit more in-depth look at these principles. But the principles by which we are selecting the variants and condition is that the first principle is the variants cause the condition with a confirmatory test available. So we don't want to be getting uncertain results where further analysis is needed. We want clarity that these variants cause the condition. The second principle is that these conditions are highly penetrant and significantly impacts quality of life within the first few years. So we're not testing for adult onset conditions, and we're not even really testing for conditions that are more likely to occur later on in childhood. It's highly penetrant childhood, early childhood onset conditions that would significantly impact quality of life. The third principle is that pre-symptomatic intervention, or at least we have good reason to believe and evidence to assume that pre-symptomatic intervention will improve the outcome in the children detected. And finally, we would include a condition if the intervention is equitably accessible to all, so it's equally available on the NHS. Next slide, please. So this is roughly what the patient experience looks like at the minute. So you can see there's a collaboration between Genomics England and the NHS, and we've put Genomics England in pink and the NHS in blue. And there's a sense in which we will be recruiting and enrolling through the NHS. Genomics England will do some of the analysis, and there will be then a handover when the results has gone back to the NHS, and then Genomics England will continue to do the research after the screening result has been given. Next slide, please. So one of the key things is thinking about how we communicate the results. We're expecting about a 1% condition suspected pickup rate, with approximately a sort of slightly less than 50% false positives. It will be done by phone call, hopefully eventually a couple of weeks after birth. It will be longer at the beginning and hopefully cut down to about 2 weeks once the pipelines are kind of working. It will be a phone call from an NHS specialist with expertise in that condition. The aim will then be to arrange an appointment for their baby and the families to be seen in the NHS specialist clinic and to have the confirmatory tests that are needed. They will include confirming that the variant has been found, but also potentially other testing to confirm or get a better clarity of the phenotype, so biochemical testing for metabolic conditions, for example. We're expecting about 99% of babies to have a no condition suspected letter. This will be a letter a few months after birth, sent by Genomics England, also to the GP. And one of the things that we're looking at with this is to try and work up some good education competencies around this, because it's really important that the result of this, especially the no condition suspected, isn't overinterpreted, because it's a limited number of conditions and a limited number of variants. If you have a child who you think might have a genetic condition, they still need all the normal NHS referrals and investigations. This isn't a sort of genetic clean bill of health by any means. And then there will be a number, of course, who will get the sample failure. Nope, yeah, continue, that's great. So by 2027, we hope to have sequenced the genomes of up to 100,000 newborns, established an evidence base as to what the screening of those babies means for the future treatment and research, and to provide data to evaluate the research study's outcomes, to essentially say, is this a good use of genetic testing, of genomic testing, and a good way to expand the newborn screening. Next slide. No, oh, that's the end one. Yes, that's it. Sorry, it was looked in. I remember having a red background. That is the last slide. Anyway, great. Okay, 10 minutes. Perfect. Leaves 5 minutes for questions. Perfect.
Absolutely spot on timing, John. And I've got to say that was absolutely fascinating and gave us a lot of information there. And it's very exciting. So Cheryl Inches from MFT, Manchester Foundation Trust, is asking, will health visitors be informed of the results?
Yes, so one of the things that we're looking at is the process by which the result is sent out, and we have, so my so I'm a job share at Genomics England. My job share is a health visitor as well. So one of the things that we do is try and create resources that are used to support our colleagues in the NHS who are going to be impacted by the study. And obviously health visitors are high on our minds in terms of people who will be talking to families. The result will be given by the specialists. One of the things we are doing and one of the things we are working on is the education and training that will be delivered to help other healthcare professionals who will come across these families and have to make sense of this result. And key healthcare professionals are going to be health visitors, nurses, midwives, GPs, paediatricians. And we've recognised that there will be a need for people to understand exactly what this condition result suspected means and a no condition response suspected means. So yes, the result will be made available. There is also going to be some education and training, sort of potentially sort of self-directed online learning and other resources. The other thing that we're doing is developing some sort of just-in-time resources. These will be aimed specifically at patients, but useful to healthcare professionals as well. So for each condition, we're going to have a hopefully condition suspected information sheet that isn't just about the condition that's suspected, but that point in time when someone's been given this condition suspected result, but confirmatory testing is in progress, because we recognize that that's a really sensitive time to both understand, well, what's happening for parents and also for healthcare professionals to go, well, is this a diagnosis or not? So there's going to be other resources as well available to parents and healthcare professionals to help them make sense of a result in those circumstances.
That's brilliant. So there's a lot going on in this space, and certainly people will be supported through study and education and training for this. Alison Bradley, one of our guests, is asking, when is the recruitment commencing, and have you chosen your centres already?
So the go live we're aiming to is going to be in December, and the plan will be to have a smaller number of centres who have been chosen to pilot it, to start it, and to look at what that would look like, and then for the recruitment to be widened. There's been a number of ways in which we've been thinking about recruitment, both in terms of practicality, so the centres who are kind of keen to do it and kind of put their resources behind it, but also one of the key things is to try and ensure that there is a diversity concern that is realised to ensure that we are diverse in our recruitment, which is important both scientific and ethically, to ensure that we maintain a diverse participation in the project. So the first centres have been chosen partly in terms of practically who's likely to be able to set it up and have a look at how this is running, partly to ensure that kind of diversity aim, and then as time goes on, that will be expanded to more and more centres as we learn practically how this is going to be running on a day-to-day basis.
Lovely. And regarding that, the diversity question, resources will therefore be translated into different languages.
Yes, so one of the things we're key to make sure is that the translations are done really well, so to target those depending on the specific area, so not just to kind of do it lots badly, but have a sense of what. One of the reasons the translations are lagging slightly is that we wanted to get all the content nailed down before we translate it, so we can then do the translations properly, as opposed to trying to do it all at the beginning and then having to go back to the translations. The consent is going to be a competency-based approach. So obviously there will be, midwives will be a significant number of people doing this consent, but actually because we're taking a competency approach, we're going to allow trusts to flexibly use the resources that they have, and the education and training for that is based on a kind of, a belief that there are multiple different healthcare professionals who could consent, and if you meet those competencies, you could consent to the study, which hopefully again will allow for kind of flexibility, because every trust is different, but also allow then that to feed into the diversity aim, in that if you can have multiple different people, you're not limiting yourself to one group of healthcare professionals, and you've got multiple people as long as they have met these kind of core competencies that are developed.
That's absolutely brilliant. Can I just say that you've actually lit up the chat with so many people are asking some questions. So as we move on to our next speaker, would I be able to ask you, John, to maybe answer some of the questions that we haven't covered in the chat?
I'll have a look through, sure.
Yeah, thank you so much. So I am delighted now to be able to welcome our next speaker. And our next speaker is Julie Cropper. Hi, Julie, welcome. And Julie is talking about MODI, and it's a case study collaboration and an MDT approach. And she's going to be explaining about roles and responsibilities. So it's genetic testing guiding clinical care. Thank you, Julie. Over to you.
Thank you, Marie. Apologies for the slightly different title. But I'm going to show why NHS England commissioned a monogenic diabetes project to ensure that there were trained monogenic diabetes leads in each trust to help with diagnosis. I'll use a case study to show how genomics can help to confirm the diagnosis and how each member of the MDT can have a part to play, either in questioning a diagnosis, asking for advice, or referring to the monogenic diabetes leads as appropriate. So if we look, for example, at this patient here, we've got a female who was diagnosed with diabetes at the age of 25. She was started on metformin, her BMI was 30, and her HbA1c was 65 millimoles per mole, or 8.1%. To put that into context, the target is 48 millimoles per millimole or below, but people can have quite higher numbers than that. And she's got a parent affected with diabetes. So if you were presented with this patient, there are a number of different types of diabetes that you could consider. I don't know if anyone wants to put anything in the chat about what type of diabetes they think this might be. You may not be that familiar with diabetes, because I know there's a lot of different people in this audience. However, it could be type 1 diabetes, which is often found in young people. We've got some people saying it could be type 2, which is true. But we can also get that in teenagers as well. As you know, type 1 we can get diagnosed at any age up until older adults. Yeah, type 2, late onset type 1. There's also something called MODI, which is maturity onset diabetes of the young, which is genetically inherited, and it is often thought to be type 2 in young people, but it's an autosomal dominant inheritance generally. So it's monogenic diabetes is a change in a single gene, which is the cause of the diabetes. So it's not very clear, as you can see. Next slide, please. So apologies for the old map. I didn't have an up-to-date one, but you can see there's quite a wide variation in the diagnosis of monogenic diabetes across the UK, with a heavy concentration in the south west, which is where the testing is done in Exeter. Monogenic diabetes is often misdiagnosed, but it accounts for 3.6% of all UK diabetes diagnosed under the age of 30. And about 80% of those are often misdiagnosed as type 1 or type 2 initially, and it can take up to 12 years to get a correct genetic diagnosis. Because of the widespread variation in the number of referrals, as I say, they commissioned, NHS England commissioned the National Monogenic Diabetes Project to improve the identification and treatment of monogenic diabetes, aiming to reduce unwanted variation in referral identification rates. And they funded training in monogenic diabetes to an identified medical and nursing lead in adults and peds in each hospital trust over the course of a year, hoping to reduce the variation in referrals and make sure people aren't on incorrect treatment and having insulin unnecessarily, things like that. Next slide, please. So what sort of things might suggest that your patient has got monogenic diabetes? There could be neonatal diabetes, which is diagnosed under 6 months of age, and it's called neonatal diabetes even as an older adult. So you can see these two patients here, Jack, who's still a young person actually, and Stephen, who was older when he was diagnosed as a baby, but he was still called neonatal diabetes when he was older. There could be MODY, which is diagnosed below the 25 years of age, and there's usually a parent or a child that has diabetes. Or there could be syndromic types, which is diabetes plus, extra pancreatic features, and an example of that is DID-MOD or Wolfram syndrome. Okay, next slide, please. So neonatal diabetes, what we used to have to do was when the diabetes was diagnosed, we had to wait until there were any other features before we could decide which gene we were going to test for, which could take some time and could cause some complications. Now, when we get a diagnosis of diabetes in a baby, we can test all the known genes using next generation sequencing immediately after the diabetes diagnosis. This enables us to predict the progress of the disease, what type of extra pancreatic features they're likely to have, and what sort of treatment is the best treatment for this condition. There are just some examples here and the different types of treatment. Next slide, please. Okay, so if we want to find MODY in the clinic, you could just say, well, there is no MODY in my clinic, and you'd be right 97 to 99% of the time. But in every diabetes clinic, there's about 1 to 3% of the people have MODY. We can't screen genetically all of the people who come to the clinics because that would be very expensive and very inefficient. So the best approach is to try and find atypical type 1, and there's some parameters here that we could use, or atypical type 2, or also whether they've got other features which could indicate a syndromic diagnosis. Next slide, please. So we're going to look at a case of Dan, and he was diagnosed at the age of 16 and assumed to have type 1 diabetes, which is a very common assumption and would be right most of the time. His random blood glucose was 16 millimoles per litre, and his HbA1c was 66 millimoles per mole. He was on insulin 4 times daily, but he was having lots and lots of hypos with hypoglycemia, which was affecting his ability to drive. He wasn't able to drive, he had to stop his lessons, and it was affecting his concentration at college. He was at agricultural college. So his mum contacted the Exeter website, and then he was confirmed to have HNF1 alpha, which is the name of the gene that had changed. This is his family tree here. The parents had taken in a family tree, but they were told, oh, he's just got type 1. So once we've got the diagnosis, he was able to stop all his insulin and transfer to just a very low dose of a glycoside tablet, which stopped his hypos and actually really improved his life and enabled him to carry on and pursue the career he wanted in farming. So in summary, he stopped his insulin, which he'd been on for 18 months, and his HbA1c improved, so his glycemic control and his long-term outcomes for his diabetes actually improved. HNF1 alpha MODY was characterised by autosomal dominant inheritance, a young age of onset. It's not insulin dependent, but you may be on insulin treatment at the time if you've been misdiagnosed. It's the most common cause of UK MODY and a progressive beta cell defect. It often presents in adolescence and young adulthood, and it's sensitive to low dose sulfonylureas. They are, however, prone to complications, particularly retinopathy and nephropathy, and there's history of MI common, so we'd put them on statins. But you can see here, he said it was May 2005, the big day where I just didn't take insulin at all. I tested my blood 48 times over 24 hours. I can't emphasise enough how different it's been. It's fantastic. You can see how anxious he was. He'd been told he needed insulin to survive, and then we're suddenly saying, well, you don't need it, we're taking you off and putting you on a tablet. And he was pricking his finger 48 times in the 24 hours. We're really lucky now we've got some better tech where you can get glucose sensors, which really help with that. Okay, next slide, please. So we can see this is just one example of the precision monogenic diabetes, to get the right person to test and do it at the right time, which is better close to diagnosis if you can, but you can do it later on because your genes don't change. We need to do the right test using the right method, testing, looking for the right genes, and then interpret the result correctly. Then that will guide the management outside pregnancy and in pregnancy. We also have something called non-invasive prenatal testing for monogenic diabetes for a glucokinase change or a HNF4 alpha change, where they can test the fetus's blood using the mother's blood and then confirm it with the cord blood afterwards. And we're doing some work on that with Denise actually at the moment. Okay, next slide, please. And that's if she wants some more information. So I'm happy to take any questions. Thank you.
Thank you so much, Julie. That was absolutely fascinating, and it's just, you know, being able to demonstrate an actual patient and the implications and the impact on that individual. We've got a great question in from Angela McAlpine, and she's asking, do they automatically do genetic testing if it's type 1 that's diagnosed as a teenager?
No, so we used to always do what they call pancreatic autoantibodies at diagnosis for type 1, particularly in children, and that's to confirm the diagnosis of type 1. Unfortunately, you can have antibody negative type 1 as well, so it's not that straightforward. And a lot of centres were still doing the old test of isolated antibodies, but they should now be doing GAD and IA2 and zinc transporter antibodies. If that is positive, then you won't take it any further and you just assume that it's type 1, because that is the most common type in young people. If there were any other features or reasons why it wasn't thought to be typical type 1, that's when they would look, or the antibodies were negative, that's when they would look further at whether they would need genetic testing, but they don't automatically do genetic testing.
Okay, that's great. And then that leads on to the second part of that question is, how can diabetics be referred for genetic testing?
But they used to have to contact the regional genetic diabetes nurses like myself, and there was only about 12 of us in the UK, and I've only got half a day a week for all of my genetic work now, and I've got a much bigger area in the northeastern Yorkshire, but there is now a named monogenic diabetes lead in each trust that we can let you know about, or you can contact them and ask them for advice or refer them on for genetic testing. But I have had some great referrals from primary care as well, so I think as long as the awareness is raised and people are looking for it, that's really important.
And it's interesting for us to hear, I think, how has genomics transformed your role?
It's hugely transformed it. I started doing the genetic work, in about 2004, I think. And we only had 2 genes that we were looking for at that time, and we had to decide what it was before we tested for it. And now we've got the whole panel of about 34 different genes that they'll just do with the first test, and we get some unexpected results. So it's really enabled us to see what the actual cause of the diabetes is and get the right diagnosis earlier and the correct treatment.
That's absolutely brilliant. So if we do get any more questions, we'll hopefully be able to reach out to you, Julie, and get those answers for the audience members, if that's okay.
That's fine, and my email's there as well if you want it.
That is absolutely perfect, yes. So if anybody wants to take a screenshot of that, we've got Julie's contact details. That really was a brilliant overview of that case study, so thank you so much. And just by way of interest, do you know who it is at Lancashire Teaching Hospital? So that's the other side of the Pennines from you.
Find out. I've only got the list of the northeastern Yorkshire leads, but I can find out at Lancashire.
That would be lovely. That's great, thank you. And all contact details, as Barbara said in the chat, can be provided following this webinar. So if you don't take a screenshot, don't worry, we're okay. I can't thank you enough, Julie. Thank you so much. It was brilliant to have you with us today. And I am delighted to be able to invite our next speaker. Our next speaker, next slide please, is Mandy Derbyshire, who is our Lynch syndrome CNS and educator in the Northwest GMSA, and she'll be talking about bowels and beyond. Over to you, Mandy.
Hello, thank you. So yes, I'm Mandy. I work up in the Northwest as the Lynch syndrome CNS and educator, and my background's previous colorectal CNS. Next slide, please, Raina. So Lynch syndrome, it's a genetic alteration which causes a predisposition to cancer. And we know that for every one person that we diagnose with Lynch syndrome, we can potentially, on average, find a further 3 additional family members that will also be diagnosed with this genetic alteration. And approximately 200,000 people in the UK have this genetic condition, but 95% don't even know that they have it. And we know that it's inherited, and that first degree relatives have a 50% chance of carrying the same pathogenic variant. And over 1,200 cases of bowel cancer in the UK with patients under the age of 50 are estimated to be caused by this genetic alteration. And this sort of led NHS England with its long-term plan and its ambition that by 2028, 75% of cancers will be diagnosed at an earlier stage. And the way we do that is through screening and testing people. But first of all, we need to find those people, especially that missing 95%. Next slide, please, Raina. So Lynch syndrome, it's a predisposition to certain types of cancer, and the main ones that we're sort of looking at are colorectal and endometrial. As you can see from the picture, the average for the general population, the risk for colorectal cancer is 5%. Now, with certain sort of genetic variants of Lynch syndrome, that can go up to 80% risk of somebody developing colorectal cancer in their lifetime. And also with endometrial, general population, it's a 2.8% risk. But somebody with Lynch syndrome can have an up to 60% risk. So you can see the big differences in these 2 specific cancers. And obviously on the back of the NHS long-term plan, NICE have also developed guidelines now for people with colorectal and endometrial cancer, so that everybody who has those cancers should be tested or do somatic testing on that tumour initially to see if they have Lynch syndrome. Next slide. Lynch syndrome is caused by genetic mutations or pathogenic variants in DNA mismatch repair genes. And these are the 5 genes that we look at when we're doing germline testing. And these genes normally protect you against certain cancers, although pathogenic variants prevent these from working correctly. So we need to see if this is within the tumour itself, so somatic testing, but then we also need to find out whether actually, is it within the patient's DNA? Is it with a faulty gene present within all the cells in that person's body, not just the cancer? And if that is the case, then we can confirm Lynch syndrome. Next slide, please. So how do we test these patients? So patients that are coming through with a confirmed colorectal endometrial cancer should be getting what we call somatic testing, so testing on the tumour in path lab. And these will identify patients that are likely to have Lynch syndrome. So that's the first test that we do. And those that are likely to have it, we used to send them all to the genetics department for genetic testing or germline testing of their DNA to see if that variant is there. We've got this new term called mainstreaming. So bringing that testing back into their local trust, where Clinicians, such as myself, will consent a patient for a DNA germline test within their local hospital, and then provide them with those results, because those results can determine whether they have targeted treatments or a particular surveillance programme. And also, mainstream is important for equity of service, trying to get those patients tested locally at home. You know, some patients might not engage with genetics due to having to travel to specialist centres, being unfamiliar with people, bringing it back to the trust with people that they know, relationships are built with, and trying to get that service to them. Next slide, please. So my aim, what's my aim? You can see on the left-hand side the testing pathway that we're hoping to change. So it says MMR at the top. So that's the initial testing on the tumour. So it used to take about on average 24 days for that testing to come back. And if they needed any further testing, such as sort of BRAF or hypermethylation, which is the next step on the testing of the tumour, that can take up to 56 days for that patient. And then if we do sort of send them to clinical genetics, waiting for that blood test, that can take up to 286 days. So that patient has waited a long time to be told, actually, you might have Lynch syndrome, to actually having a result for that. Now, you can see on the right-hand side, this is our ideal pathway. We're wanting patients to have that testing done, be seen at their local trust, and actually get that result within 62 days. We're giving ourselves a target. Now, from my personal point of view, I've actually seen a patient in August and actually saw them today with their results. So that pathway is already changing. And instead of making a patient worry with anxiety or anything like that for potentially a year, I've hopefully given that patient an answer within about 8 weeks, which is a massive difference to patients. And that's the aim. And that's what we're talking about, mainstreaming, bringing it back into trust and providing that service to patients. Next slide. So how do we manage these patients who've been confirmed with Lynch syndrome? So these patients, we would refer into the clinical genetics department, who will go through all sorts of counselling with them, cascade testing for their family members, and also surveillance or risk reducing factors. So a colonoscopy for certain gene variants, we'd start colonoscopies at the age of 25 and do that every 2 years. And for other variants, it's age 35 for every 2 years. And that's been taken on by the bowel screening programme, which the clinical genetics department sort of enter the patients into. We know that through the CAP2 study, the aspirin can be a really good drug for these patients to take. And actually, we found through that study that patients can reduce their risk of cancer by up to 50% if they take the aspirin for at least 2 years, if not longer. But I know that they're working through dosages at the moment with that study. But you can see on the right-hand side the sort of link to the article. Patients with Lynch syndrome get a one-off gastroscopy where we test for H. pylori, because we know that if H. pylori is present and we can give them eradication therapy, then again that can potentially reduce their risk of developing gastric cancers by 50%. And lifestyle modifications, diet and exercise. If they've got a colorectal cancer, again, with particular variants, we can talk about surgery. Do we need to do total colectomy rather than a segmented surgery? Because we know some genes, they are more at risk of metancrinous bowel cancers. And personalised oncological therapies, such as immunotherapies for these patients, we know they respond really well to immunotherapy. And also for those, the females with prophylactic surgery, so risk-reducing surgery, such as the hysterectomy and oophorectomies as well, for those that are over 40. and PGD, which I call a fancy IVF. So it's called pre-implantation genetic diagnosis. And this is amazing for people to be offered, where they can actually look at the embryos. They can take away the embryos that have that Lynch variation and only implant the ones that don't have that genetic variant, trying to prevent the child from having that gene variant and having to go through all of this surveillance and the risks of developing bowel and endometrial cancer. Next slide, please. Now, this is for everybody else, so this is a bit of your learning, so this is what you can do. So there's lots of online resources to help with learning about the pathways of Lynch syndrome. So this is your option 1 on this left-hand side. So it talks you through the pathways and what we're testing and how we're testing and how people are selected into going on for germline testing. Then option 2 is about what is mainstreaming, why are we mainstreaming, how to talk to patients about having those genetic conversations and consenting to a germline test, and doing family pedigrees and seeing whether there is a trend within those that family. So the links are there. And then once you've done that, if mainstreaming is something that you're passionate about and you want to provide that service for your patients in-house, then for the Northwest, I do provide mainstream training, and that's all via Teams with myself, and that's 6 sessions of tailored training for you so that you know how to have that genetic conversation with that patient and how to talk to patients. And that's me.
Mandy, absolutely brilliant, because it's such a comprehensive overview of Lynch syndrome, and particularly in those 2 pathways that you're talking about, colorectal and endometrial. If it was a thing that people on the call and the audience would want more signposting because they'd like more information on Lynch syndrome, where would you recommend that professionals go to learn more about A, the Lynch syndrome, and B, the associated testing?
Well, we have an amazing website for the Northwest GMSA, so I would just like to point that one out. But all the GMSAs do have websites that you can look at and refer into. I am more than happy to answer any questions. I can put my email in the chat. But we've done lots of online teaching. We've got Reef webinars that I think are recorded and that you can get hold of that talk through the process of genetics, from basics all the way through the Lynch testing beyond and what we want for mainstreaming. So there's lots of resources out there.
Yeah, and if you were to give advice to anybody who was looking to transform their own patient pathways through mainstreaming, what's the one thing that you think is the secret to making it happen?
Not to be afraid of change, because this type of change is going to benefit your patients massively. And although there might be little challenges ahead, perseverance, because at the end of the day, it's the patients are key, and that pathway showing from the experience of waiting for genetic results to what you can provide that patient in-house. You know, we're all experienced healthcare professionals, and we all love learning, and we love developing, and everything is about the patient. And I think anybody can change a service or develop a service at any point in their career. And I think don't be afraid is the key. Ask for help. Look out there. People are doing it in different trusts. So how are people doing it? How have they got there? How can I implement it where I am? Don't invent the wheel. There are people out there like myself who've developed a service. We're here to help, and reach out, but don't be afraid, because at the end of the day, this will benefit the patients massively, and that's what we're all here for.
I think that's such an important thing that you've shared with us there, that it's that encouragement and that reassurance that, you know, this is about the patient. This is taking it back to why we do what we do. We're transforming patient pathways at the end of the day, aren't we?
Yeah.
Now, I know you've been dealing with patients quite a lot recently who are mainstream. And there's a question here that what would you say are the main concerns or questions that people are having when you're having those mainstreaming conversations with patients?
The biggest one patients always ask me is, how's it going to affect my children? And what about insurance? They panic a lot about other people, I think, is the biggest one from patients, because they too don't feel it's not just their diagnosis, it's not just affecting them. Genetics is a family diagnosis and it affects everybody. So the biggest one that I've had, especially today, is, well, what about my son? What about my daughter? What happens next? And it's the reassurance of, don't worry, we're going to get to that. Let's deal with you first, and then the next step is on your family. And the clinical genetics department are amazing. They're not people to be afraid of. They're there to support you, and they will help wherever they can. And that was the biggest question that patients asked me: what about my family? Don't worry, we can support your family, and this is what will happen next when you go to the genetics department. And I encouraged somebody to take their son who came for the results today with me. I said, you go with him and you can sit and you can have the discussion together, and that support network as well. And with insurance, we always sort of talk them through the insurance part side of it, and refer to the sort of document that we have for, I think it's code of for insurers. So I usually refer to that and talk through them. But the biggest worry is family.
It's for others, which is quite humbling to hear, isn't it?
Yeah.
Honestly, thank you so much for such a fantastic presentation of Bowels and Beyond, which I think is a real catchy title, which then takes us on to our next catchy title. I am delighted to be able to welcome here today a colleague of mine and friend called Julie Goodfellow. Julie's a lead nurse over at the NHS North Eastern Yorkshire Genomic Medicine Service, and she's taken it right back to the heart of the matter, and she's going to be talking about inherited cardiac conditions. Over to you, Julie.
Thank you, Marie, and thanks to everybody who's stuck with it. It's been a long afternoon. There's been such a lot of interesting talks about various aspects of genomic healthcare at different stages in your life. I'm a specialist nurse in inherited cardiac conditions and have been for around about 16 years. So I've been dealing with some very difficult issues around conditions that can affect the heart that are inherited. And today I'm going to talk to you a little bit about inherited cardiac conditions because we haven't got much time to delve deeply into it. But probably the most emotive and the most distressing aspect of it, and that is sudden cardiac death that is caused by inherited heart disease. Can I have the first slide, please? Thank you. So you may recognise some of these people. I've put them up here because the first symptom that these people had of having an inherited cardiac condition was a cardiac arrest. On the top left-hand picture is Christian Eriksen, who you may have seen just 2 or 3 years ago collapse on the pitch whilst playing in the Euro Football Championship for Denmark. And he was very lucky that all of the right people and equipment were there, and he was resuscitated successfully and is now playing football again in the Premiership. I assume he's got a subcutaneous ICD in, because if he had one in the middle of his chest, he wouldn't be able to play at that level. The guy underneath him is Patrice Muamba, who you may remember had a very long cardiac arrest, and it was awful to watch on the pitch whilst playing football. I think for Bolton, I'm sure that Jill, who's a Bolton supporter, will tell me off if I've got that wrong. And he was subsequently diagnosed, when he survived, with hypertrophic cardiomyopathy, and that was confirmed genetically, and his sons have also got that condition. The older guy on there, for those of you of a certain age, will recognise him as David Frost. And David Frost was a TV presenter for many, many years and was diagnosed with hypertrophic cardiomyopathy. Sadly, he wasn't told, and his family weren't told, that this could be inherited. And so his family didn't undergo clinical screening. And the young man next to him is Miles Frost, who was his son, who unfortunately went out for a run at the age of 33 and never came back, and he was found deceased. The family have raised awareness of screening and the importance of screening for inherited cardiac conditions, and have worked with the British Heart Foundation, raising lots of money to actually put specialist nurses into trusts right around the UK. The top right-hand black and white picture, the guy who is here trying to get the ball is Terry Yorath, who is a football player of old, and his son Daniel, who sadly, whilst kicking the ball around the garden with his dad at the age of 15, dropped down dead. You may know his sister, Gabby Logan, who's also a TV presenter. And these are very high profile cases of where people had a cardiac arrest before they knew that they had a diagnosis of anything. And this is not unusual. And that's what I want to talk to you about today. Next slide, please. There are around about 100,000 sudden cardiac deaths per year in the UK. Most of these are not due to an inherited cause. Most of them are polygenic, or they are multi cause, and they're caused a lot by lifestyle, smoking, being overweight, having high blood pressure, all of those things. Most of them are caused by coronary heart disease. However, 5 to 10,000 of these have a genetic heart disease diagnosis. I think this statistic is really quite scary, that every week in the UK, about 12 fit, healthy young people die suddenly from a previously undiagnosed heart condition, just like the ones we've just talked about. Most of these genetic heart conditions affect young people, young adults and teenagers. And the important thing to remember is, because it's genetic and because these conditions are passed on in an autosomal dominant fashion, it means that 50% of their relatives, male and female equally, can be affected and can also be at risk of sudden cardiac death. Next slide, please. So what are these conditions? Well, there are a variety of them. They're kind of structured into structural heart problems, things that affect how the heart is put together, and electrical conditions. So you can't see them when you look at the heart. You can only see them in life when you're looking at the electrical side of the heart. One of the commonest conditions is hypertrophic cardiomyopathy. I've mentioned that already. About 1 in 500 of the UK population are affected by this, and at least 50% of them are genetic. Dilated cardiomyopathy is another heart muscle problem that causes the heart to get big and floppy, in the main pumping chamber in particular, a bit like an overblown balloon, and that's quite common. It says on this statistic 40 to 50% of them are inherited. I suspect anecdotally from my work that it's more than that. We just haven't got the evidence to prove it. And then we have the next three conditions, which are electrical conditions that affect the heart, or channelopathies, and they affect the channels that open and close in the cell membranes of the cardiac myocyte, the heart muscle cells, that allow electrolytes across, charged particles that make a current of electricity go through the heart and affect and make the heart beat in an organised fashion. Long QT syndrome, Brugada syndrome, which is sometimes called nighttime nocturnal death syndrome, because people quite often die in their sleep, and catecholinergic polymorphic ventricular tachycardia. You can see why we shortened to CPVT, which is a condition that affects young people when their adrenaline is flowing, so when they're excited or when they're scared, when they're exercising. They can just have a fatal cardiac arrhythmia and not wake up again. Then you get arrhythmogenic right ventricular cardiomyopathy, which is a little bit misleading because it can also affect the left ventricle, which is the main pumping chamber of the heart. All of these conditions are inherited. Familial hypercholesterolemia is worth mentioning. We talked about some of those deaths, the 5 to 10,000 genetic heart diagnoses. Many of those are down to people having a premature myocardial infarction, a heart attack, as opposed to a cardiac arrest. And a heart attack is a blockage in a coronary artery, which causes a bit of the heart muscle to die. This can happen if you have a high cholesterol, and in families with familial hypercholesterolemia, they have very high cholesterol levels. If you come across any patients with a pre-statin treatment cholesterol of greater than 7.5 millimoles per litre, please ask advice from either a doctor who knows about these things, a lipidology clinic, or from your local clinical genetics, because it might be familial hypercholesterolemia, and it's very, very treatable. Marfan syndrome, you may have heard of that. I've put that down as an example of connective tissue disorders, which are always inherited. These conditions can cause a stretchiness in the connective tissue, the most important thing being in the vascular tissue. And often people with Marfan's and other aortopathies, which are genetic, have a stretchiness to the point where they can have an aortic dissection, and that can be the first symptom, and therefore they die. And the bottom one is a little bit rarer, but we do come across it, progressive cardiac conduction defect. This is in families where you might find that people in their 20s and 30s are having atrial fibrillation, whereas they shouldn't be getting it probably until their 60s and 70s, and there's no reason for it. Or they might have heart block, and you might find that people in their 30s and 40s have got pacemakers where they wouldn't ordinarily be expected to have them. Next slide, please. So how do we help these families? Well, once we know that there is a problem, if somebody's either died or survived a cardiac arrest or been given a diagnosis, we investigate the families for inherited disease. We screen first-degree relatives. We do this because early detection can decrease the severity of disease and increase treatment choices. It decreases uncertainty and therefore reduces stress, and it increases knowledge for that patient, and they can adjust their lifestyle to try and avoid scenarios that can increase their risk. For instance, with Brugada syndrome, more people with Brugada syndrome have a cardiac arrest when they have a high fever than at any other time, so we can give them advice about that. The important thing to remember when we're helping these families is that we can actually save lives by screening first-degree relatives. Next slide, please. So how do we do it? Well, we sit down in a clinic and we talk to people. We give them advice about their condition. We find out about their family, and we draw up a 3-generational pedigree, family history. We ask particularly about when people have died, at what age, what conditions they had, and then we try and confirm that. We arrange for them to have echo scans of the heart, ultrasounds of the heart, 12-lead ECGs, and in some of the electrical conditions, we might stick them on a treadmill or give them a drug which might change their ECG and help give them a clinical diagnosis. And these days, since the advent of the genomic test directory, if they meet criteria for specific tests, then we will do genetic testing. Just a word of caution, it's important that if you're doing genetic testing in mainstreaming outside of clinical genetics, that you know what you're talking about and you can talk through the options of the potential outcomes. Next slide, please. Just to finish off, I want to share this lovely photograph of this fabulous family. The lady with the blonde hair in the front, in the back, is Fiona, who was diagnosed incidentally with long QT syndrome when she had a pre-op ECG for a small procedure. When she was referred to the clinic, she'd already had a genetic diagnosis confirmed. I drew up her family tree and she told me about her dad, who was the chap in the photograph. He turned 60, he went out for some drinks with some workmates, came in a little bit merry, sat in the chair, went to sleep. His wife put a blanket over him and went off to bed. And sadly, when she checked on him, because he hadn't come to bed at 3 o'clock in the morning, he was no longer alive. I advised Fiona that her first-degree relatives should have some clinical screening, but they didn't really seem to take it very seriously and didn't come forward at that time. Roll on 3 or 4 years, and the young girl at the left, at the front, she had a collapse. That's Ruby, and she had a collapse while she'd been playing football. Luckily, she spontaneously came back, and her arrhythmia, we assume it was an arrhythmia due to long QT syndrome. When she came into the hospital, she was diagnosed with long QT syndrome. I was asked to see her mum, who was pregnant with the little boy holding the picture at the time. We were able to offer predictive testing once we put 2 and 2 together and realised they were the same family to all of these members of the family. and to some others as well. And to date, 17 members of this family have been tested, and every single one of them has the gene mutation that causes long QT. None of them, since Dad, have collapsed and died. They're all on preventative treatment with beta blockers. None of them have got a defibrillator, but they all know how to use an external automatic defibrillator, and they have them in their homes.
Wow.
This is the benefit of genomic testing.
Brilliant. Absolutely unbelievable. And, you know, can't thank you enough for an excellent presentation and truly bringing us back to the heart of the matter. Thank you so much. And we're going to go back to our very own Jill Moss, who is kindly going to close our meeting for us. Thank you, Jill.
Thanks, Marie. So my final words are to thank everybody for joining today. We really appreciate that you've taken time out of your very busy schedule to find out more about genomics in modern medicine. The presentations yet again have been of extremely high calibre, and I'm sure they've been thought-provoking. If I can only ask you one thing to do today, and that is to share with 3 of your colleagues what you've learnt and what you've liked about genomics, as this will assist us in sharing genomic knowledge, which of course in turn will strengthen genomic confidence across the nursing workforce. So once again, thanks for joining, and of course we'll let you know when we have our next webinar, and we certainly hope that you will join us. Thank you very much indeed.